So, attention can be measured in a number of different ways, and attention has been described in a number of different ways. In other words, there are types of attention: sustained, divided, etc. And these schemes describing types of attention don't always match up from theory to theory, from author to author, from test to test. Sometimes they use terms like focused attention, and another author will use the term selective attention. These are synonyms. I think what you see in speech pathology land is people following a scheme developed by Solberg and Mateer in, I believe it was the early 90s. Before then, most of the discussion about attention was really coming out of psychology and a laboratory. In other words, very narrow psychological research. In Solberg and Mateer kind of came up with a scheme of attention to try and address the fact that many of the ways attention was described was not in harmony with the clinical observations that they were having, and so they did their best to be true to both the research and some of the theories out there and their own clinical experience. And they came up with this notion that basically we have sustained attention, our ability to sustain attention over a period of time. We have selective attention, also known by other authors as focused attention, our ability to both sustain our attention but do so in the context of some distracting stimuli going on. Alternating attention, our ability to move our attention from one object or activity back to another, and so forth. And then, hope I'm not forgetting any here, and then finally, divided attention. So divided attention is hypothetically this idea that we can pay attention to two things at once. And I think I've mentioned early on in the lectures in these classes that notion that we can that we really can pay attention to two things at once is up for debate. So a lot of clinicians will take that scheme by Solberg-Mateer and come up with informal assessments that try to focus on these abilities. And in some ways that can be quite useful, right? I mean, in other words, if your purpose isn't to come up with a diagnosis and have the backing of a standardized test instrument to help you out, well, you could make the argument that testing sustained attention in a task that's relevant to the patient, such as sustaining their attention towards some activity of daily living, reading, whatever, or perhaps being able to sustain their attention on reading something while there's distracting stimuli, etc. That there's a certain kind of clinical logic to that where we could tailor our informal testing to the goals that the patient have. If they were academic goals, then we could try to find a way to construct attention tasks that were academic, essentially. The test of everyday attention is, of the formal test batteries, is probably the most common one that we see used by speech pathologists. it that tries to mimic, or its purpose is to mimic, everyday kind of functioning. And you can see here how by the description of some of the tasks that there is some resemblance to real-world activities. I included a fair amount of discussion on the research on the TEA. And my purpose in doing that is just to give you a little peek behind the window to realize that tests that don't necessarily always test what they say they test. And oftentimes the research that's done on these tests can be conflicting. It's good for us to be aware of that, if for no other reason not to get religion. And if the test tells us that a person has this problem, that we take that message from the test with some kind of reflection. One nice thing about the TEA is it has a parallel form, so you don't have to worry about test-retest interference. You can give one form before you begin your attention therapies, and then after some time give the other form and have a more objective measure of whether or not the patient has made any improvement. Solberg and Mateer, the authors of this kind of clinical approach to attention that so many speech pathologists subscribe to, have what's called attention process training. And this is a kit that you can buy that has a bunch of discrete attention tasks focused on these different areas of attention that they've identified. And I can't think of a clinic right now that I've worked in that hasn't had that kit there. So it's, from my perspective, it seems popular. In case you end up working someplace and they have an old version of attention process training, Solberg and Mateer not too long ago have really revamped their conception of how to treat attention. Early on, their focus was really on kind of stimulation, restoration of attention skills, and now they've moved more towards developing good self-monitoring skills, strategy approaches to dealing with attention, emphasizing much more of what we would call executive forms of attention. And so executive forms of attention are kind of those forms of attention that require a lot more conscious application and self-monitoring. Divided attention certainly is one of those. Anyways, they have not too long ago put out an attention process training test. I don't have the manual for it, so I don't know the psychometrics on it, etc. I have confidence in those authors, so I'm sure that it may be a useful, clinically useful test. I haven't gotten a peek at it yet. Finally, the Moss Assessment Attention Rating Scales, which I've provided a link where you can download it for free, I think is also a nice measure because it's so functional. And some of the complaints, if you look at that rating scale can be used to kind of discover complaints or problems that you may not have detected in an interview and get a rating for them. And that can be the basis for starting to talk to patients more about these problems and determining whether or not this needs to be an area that is focused on in treatment.